a narrative review of Eponymous Cardiovascular Surgeries for thoracic, congenital, and pediatric heart diseases. A tribute. Hand of God. Dr. Kamcharian, Katarothamammancharian, March 8, 1942 to January 25, 2025. In our society, eponyms play an important role, helping to identify or explain many things. According to Webster's 9th New Collegiate Dictionary, an eponym is 1. The person for whom something is or is believed to be named. 2. A name, as of a drug or a disease, based on or derived from an eponym. Individuals in medicine who are fortunate enough to be recognized as, or by, an eponym usually take pride and some comfort in knowing that they might thereby, in some small measure, be immortalized. Advances in pediatric cardiology and cardiac surgical techniques over the past few decades have revolutionized the management of the patients with congenital heart disease, CHD, and many now survive into adulthood. Several eponymous surgical procedures performed for CHD have been named after eminent surgeons, which are illustrated in this narration. Dr. Alfred Blalock, 1899 to 1964. Vivian Thomas, 1910 to 1985. Dr. Helen Taussig, 1898 to 1986. Blalock-Taussig shunt. Alfred Blalock, 1899 to 1964, had built his own animal laboratory while working at Vanderbilt following his surgical residency, conducting research on cardiovascular surgical procedures and shock. In 1930, Vivian Thomas, 1910 to 1985, joined Blalock's laboratory and assumed a central role in many of his research projects. Blalock and Thomas developed an experimental model of a dog with cyanosis and subclavian to pulmonary artery shunt. When Blalock assumed the chairmanship of surgery at Johns Hopkins in 1941, Vivian Thomas accompanied him to Baltimore, where they encountered Helen Taussig, the head of cardiology clinic at Hopkins. Helen Taussig, 1898 to 1986, approached Blalock with the idea of creating a shunt that stimulates patent ductus arteriosus to increase pulmonary blood flow for palliation of a blue baby with pulmonary stenosis. In 1944, Alfred Blalock and Helen Taussig introduced a systemic to pulmonary artery shunt for tetralogy of Fallot, which was then a pioneering surgical procedure in the field of pediatric cardiac surgery. Potts shunt. Dr. Willis Potts, 1895 to 1968, was born in Sheboygan, Wisconsin. After serving as a sergeant during the First World War, he completed a surgical residency at the University of Chicago in 1922. Potts developed numerous surgical equipments that are still widely in use, such as partial occluding clamp to prevent spinal cord ischemia from aortic cross-clamping. Potts shunt was introduced in 1946 to provide palliation for cyanotic CHDs such as pulmonary artery stenosis and tricuspid atresia. Potts shunt was taught to represent a valuable alternative for neonates in whom Blalock-Taussig shunt, BTS, was not technically feasible and also had a lower risk of shunt thrombosis and occlusion as it does not involve small caliber vessels such as subclavian artery. Potts shunt is a side-to-side anastomosis of the left pulmonary artery, LPA, to the descending aorta to supplement pulmonary blood flow. Waterston shunt. Dr. David Waterston, 1910 to 1985, is an English pediatric thoracic surgeon who founded the first pediatric catheter-based unit and research program in the United Kingdom at the Great Ormond Street Hospital for Sick Children in London. Waterston and his team pioneered the first heart and lung bypass machine for children in 1962. In 1962, he developed the Waterston shunt, which is a side-to-side anastomosis between the right pulmonary artery, RPA, and the ascending aorta for patients with tetralogy of Fallot. July 7, 1954. Operation on a 2-year-old boy televised. The beating heart of a 2-year-old boy was televised yesterday during an operation. It was all part of the meeting of the experts which forms the British Association of Pediatric Surgeons, at the Hospital for Sick Children, Great Ormond Street, London. The operation was performed by Mr. David Waterston, and the TV camera was aimed over his shoulder. The boy had a complicated disease of the heart, and Mr. Waterston said he would probably die within 12 years if the operation were not performed. Glenn procedure. Dr. William Glenn, 1914 to 2003, was born in Asheville, North Carolina, and started his medical career as a field surgeon in the Army Medical Corps during World War II and later established a field hospital in Normandy. Glenn's ingenuity was apparent when he developed an artificial heart using tools from a child's erector set in 1949. In 1958, he reported the use of a temporary shunt between the superior vena cava, SVC, and pulmonary artery branch for cyanotic CHD. Unlike systemic pulmonary artery anastomosis, cavopulmonary anastomosis is a low-pressure system and thus is associated with lower risk for pulmonary artery distortion and late vascular obstructive disease. The original Glenn shunt is established by a. ligation of the SVC proximal to its entrance to the right atrium, RA, and patch closure of its caudal end, b. division of the RPA from the main pulmonary artery, and c. end-to-side anastomosis of the cephalad end of SVC to the RPA. The original Glenn shunt has been largely replaced by a modified Glenn shunt or bidirectional Glenn shunt, BDG, in which the RPA remains in continuity with the LPA. The main pulmonary artery is separated from the heart and oversewn. Fontan procedure. Dr. Francis Fontan, 1929 to 2018. Francis Fontan is a professor of cardiac surgery at the University of Bordeaux, France, and the president of the Scientific Council of the Center for Cardiothoracic Surgery. Fontan was the first to completely bypass the right heart by diverting all the systemic venous blood from both the SVC and inferior vena cava, IVC, to the pulmonary artery in 1971. Over the years, the Fontan procedure evolved into a multistage operation and is now used in numerous complex cardiac defects. Fontan procedure is usually performed approximately 18 to 36 months following a BDG procedure and provides definitive palliation. Kawashima procedure. Yasunari Kawashima, 1930, was born in Osaka, Japan. He trained as a pediatric cardiothoracic surgeon at the Osaka University Medical Center, where he practiced as the chief of the Department of Surgery until 1991. He was the first surgeon from Asia to enter the Pediatric Cardiology Hall of Fame in 2003. In 1984, Kawashima reported his initial experience with the procedure for single-ventricle physiology and an interrupted IVC, called the bilateral BDG or Kawashima procedure. This offers a mid-stage palliation for the Fontan in patients with polysplenia syndrome with interruption of the IVC, including persistent left SVC, bilateral SVC, and azygous continuation of the IVC. Norwood procedure. After completing his training at the Children's Hospital of Fairview University Medical Center, William Norwood, 1941, became the chief of cardiothoracic surgery at Alfredo I. DuPont Hospital for Children in Wilmington, Delaware. In 1983, Norwood and colleagues described the first palliative procedure for HLHS as an alternative treatment to orthotopic cardiac transplantation, which is limited by availability of donor hearts and complications of obligatory lifelong immunosuppression. HLS includes lesions that cannot support systemic circulation and depend on ductus for initial survival. Norwood procedure consists of a staged surgical approach that creates a new systemic circuit to transition an infant to definitive repair. Dr. William Norwood. Sano Shunt. Shunji Sano, 1952, completed his medical school and cardiovascular surgery training at the Okayama University Medical School in Japan. Sano is renowned for his contributions to the pediatric catheter-based surgery, including the development of a Sano shunt in 2003, which is the latest modification of the Norwood procedure for HLHS. Sano shunt is a conduit between the RV and the pulmonary artery, which is used in the first stage of Norwood procedure instead of BTS, to re-establish pulmonary blood supply. Damus K. Stansel, DKS operation. In the early to mid-1970s, three authors, Paul S. Damus, Michael K., and Horace C. Stansel, independently described a new procedure to relieve ventricular systemic outflow tract obstruction for patients with transposition of the great arteries, TGA, and ventricular septal defect, VSD. In the DKS procedure, the pulmonary artery is transected near its bifurcation, and the proximal end is anastomosed to the side of the ascending aorta. This bypasses the systemic outflow obstruction and ensures unobstructed blood supply to the systemic circulation. The distal pulmonary arterial blood flow is established with a modified BTS, BDG, or an extracardiac Fontan procedure. Later modification of the DKS procedure includes surgical closure of the aortic valve to prevent development of aortic valve insufficiency, and patch augmentation of the aortic arch if the arch is hypoplastic. Dr. Paul S. Damus, Dr. Michael Peter K., Dr. H.C. Stansel. Mustard procedure. William T. Mustard, 1914 to 1987, was born in Clinton, Ontario, Canada. After graduating from the University of Toronto Medical School in 1937, he had two brilliant surgical careers, first as an orthopedic surgeon and then as a cardiac surgeon. He is one of the first to perform open-heart surgery using a mechanical heart-lung machine in 1949. The Mustard operation for TGA was first introduced in 1964, following 9 years of unsuccessful attempt at an arterial switch using a monkey lung as a biological oxygenator. Dr. William T. Mustard, 1914 to 1987. Senning operation. Dr. H. Senning, 1915 to 2000, was a pioneering Swedish cardiac surgeon. He was the head of the Department of Experimental Surgery at Karolinska Hospital in Stockholm, Sweden between 1956 and 1961. Senning first performed the Senning procedure for TGA in 1957, though it was first proposed by Albert and colleagues in New Orleans in 1954, also called as Albert operation by them. Jatene procedure. Dr. Adib Jatene, 1929 to 2014. Adib Dominoes Jatene is a Brazilian thoracic surgeon and one of the founders of the University of São Paulo Heart Institute. In 1975, Jatene first described his procedure, which was a monumental contribution to the treatment of DTGA. His innovative technique was able to overcome the physiological issues of atrial switch procedures. In the Jatene procedure, the right and left coronary artery buttons are removed from the aorta. Next, the ascending aorta and the pulmonary artery are transected, and the aorta is relocated behind the pulmonary artery, which is called as Lecomte maneuver. Lecomte procedure. Dr. Yves Lecomte is a French pediatric cardiac surgeon who developed the Lecomte maneuver, a surgical technique used to repair certain types of congenital heart defects. Introduced in 1981, initially called reparation à leadage ventriculaire, or REV procedure, involved passing the ascending aorta posterior to the pulmonary artery. This technique maximized the length of the newly constructed aorta, which reduced kinking and damage to the coronary arteries. The Lecomte modification of the Jatene arterial switch is currently the standard procedure for TGA and can be performed in the neonates within the first to second week of life. Rastelli procedure. Dr. Giancarlo Rastelli, 1934 to 1970, was an Italian cardiac surgeon who trained at the University of Parma Hospital. He continued his practice at the Mayo Clinic after 1960. In 1969, Rastelli developed a novel surgical procedure that revolutionized the management of DTGA with VSD and some degree of left ventricular outflow tract (LVOT) obstruction in children who are not suitable for Jatene procedure. Rastelli died of cancer at just 36 years of age in 1970. Rashkind procedure. Dr. William Rashkind, 1922 to 1986, was the chief of the Division of Pediatric Cardiology at the Children's Hospital of Philadelphia until his death in 1986 from malignant melanoma. He was one of the founding fathers of the field of interventional cardiac catheterization. He also developed surgical devices for closure of the atrial septal defects and persistent patent ductus arteriosus. Rashkind and Miller first performed this procedure in 1966. Ross procedure. Dr. Donald Ross, 1922 to 2014, was born of Scottish parents in Kimberley, South Africa. He finished his training in England at the Royal College of Surgeons. He later became consultant surgeon and director of the Department of Surgery at the Institute of Cardiology in London. In 1968, Ross performed his first heart transplantation in the United Kingdom. The first Ross procedure was performed in 1967. Waldhausen procedure. John A. Waldhausen, 1929 to 2013. Graduated from the Penn State University Hospital and completed pediatric surgery training at the University of Virginia Medical Center and University of Washington. In 1966, Waldhausen proposed an alternative procedure for aortic coarctation and hypoplastic aortic arch. Bentel procedure. Dr. Hugh Bentel. Aortic root replacement with reattachment of the two main coronary arteries was originally described by Hugh Bentel and Anthony de Bono in 1968. Dr. Anthony de Bono. The operation has undergone many alterations during the past 3 decades. Notable adaptations have been the creation of an aortic cuff around the coronary ostia and extensive mobilization and attachment of the coronary buttons. Although the operation was originally designed to treat patients with aortic root aneurysms, the indications for radical root replacement have expanded. The Bentel procedure has led the way for the development of other techniques for root replacement, such as aortic valve sparing procedures. Bachtelek hernia. Dr. Vincent Alexander Bachtelek, 1801 to 1883. Bachtelek's hernia is a congenital diaphragmatic defect first described by the Czech anatomist Vincent Alexander Bachtelek, 1801 to 1883, in 1848. Bachtelek identified the posterior lateral defect in the diaphragm, where abdominal organs, such as the intestines or spleen, herniate into the thoracic cavity. This type of hernia most commonly occurs on the left side due to the later fusion of the diaphragm during fetal development. While typically diagnosed in neonates with respiratory distress, it can remain asymptomatic until later in life, with patients presenting with nonspecific symptoms like chest pain or gastrointestinal issues. Diagnosis is confirmed through imaging, such as X-rays or CT scans, which reveal displaced organs. Surgical repair, aimed at closing the defect and repositioning the herniated organs, is the standard treatment. Early intervention is crucial to improving outcomes and preventing complications. Morgani hernia. Dr. Giovanni Battista Morgani, 1682 to 1771. Morgani hernia is a congenital diaphragmatic defect first described by the Italian anatomist Giovanni Morgani, 1682 to 1771, in 1769. It occurs at the anterior, superior part of the diaphragm, where a defect allows abdominal contents, such as the liver or intestines, to protrude into the thoracic cavity. Unlike Bachtelek's hernia, which is more commonly found on the left side, Morgani hernias are usually located on the right side of the diaphragm. This hernia often remains asymptomatic in infancy, with symptoms typically emerging later in life, such as chest pain, respiratory distress, or gastrointestinal issues. It may be diagnosed through imaging studies, such as X-rays or CT scans, which show the herniated organs in the chest. Surgical repair. which involves closing the diaphragmatic defect and repositioning the organs, is the primary treatment. Early diagnosis and intervention are important for preventing complications and improving patient outcomes. Pendey-Potok hernia, Dr. Vishal V. Pendey. Dr. Hariax Potok. The Pendey-Potok hernia is a pediatric variant of the congenital Blalock-Taussig hernia, described first in 2024 by two surgeons from India, Dr. Vishal V. Pendey and Dr. Hariax Potok. It is the first reported case of a 4-year-old female with a congenital right-sided Blalock-Taussig hernia having intrathoracic herniation of the appendix, with a concurrent patent ductus arteriosus. The patient was successfully managed surgically with bilateral thoracotomies and ligation of the PDA and primary repair of the diaphragmatic defect with composite mesh reinforcement. This case highlights a complicated presentation in a pediatric patient with a successful surgical technique tailored to the disease process.